Thank you both very much. And we did actually get a number of questions, so we will try to go, if we can go to maybe 5 after 8 would be great if you have that time. So let me go ahead and start with the questions. I think you actually started to answer the first question. Are preservation strategies appropriate for TP tumors with variant histology such as micropapillary? So maybe you mentioned that really quickly in your last couple of slides, Dr. McKinnon. And
Sure.
Dr. Lee, you want to weigh in on that at all?
Well, I'll take a crack at it first. All the variant histologies, particularly micropapillary, tend to be less likely to respond to chemotherapy both locally and systemically. So that's a very specific high-risk subset of patients. In general, we're very cautious about recommending anything conservative to those patients. It is possible to have a pathologic complete response with muscle-invasive variant histology. So some patients who have their bladder removed will find no cancer, even if they had micropapillary, squamous, adenocarcinoma, glandular features, but it's less likely than if they have pure urothelial cancer. So I would say caution is advisable there.
And I agree with that. The other reality is that those patients that have those alternate histologies are generally not at the center of the patient population undergoing these trials. So a lot of times those patients may even be excluded from some of our research, some of the larger clinical trials. So we don't fully understand how what the natural history of some of those tumors are. So I also think we have to move with caution in patients who have those variant histologies.
So of the 14.7% of trimodality therapies who have patients who've recurred and go on to a radical cystectomy, what are their general oncologic outcomes? Is radical cystectomy successful for them as it would have been if it had been used as a primary treatment?
Yeah, I mean, we have to remember again, over time, the number of patients who have to have their bladder removed is shrinking after the trimodality therapy, in part because we're getting better at selecting patients, frankly. But there's still a small percentage of, upwards of 10% of people that may not survive their cancer long term, even though they did have to have a subsequent bladder removal. So sometimes the window of cure has closed. So we have to keep that in mind. The majority of patients who are having trimodality therapy can be salvaged with radical cystectomy or still achieve a cure if they're caught early, but certainly there is a proportion of patients, and that used to be probably closer to a third. I would say now it's closer to 10 or 15%.
Yeah, I would just add there that we have to be cautious because when we only operate on people for whom a treatment didn't work, it is inherent that those patients are a higher risk group than everybody else. So for instance, if someone receives platinum and radiation and their cancer relapses, their outcome with surgery is by definition going to be worse, not because they chose that treatment, but because it didn't work. So when patients respond to a treatment, that actually is an indicator that their cancer is less aggressive or more sensitive to chemotherapy. But if you only analyze surgical outcomes on chemotherapy refractory patients, it will appear that the surgery does not work very well.
Can you both, either one of you, comment about using narrowband imaging during cystoscopy, or in the case of blue light, using the cystute and blue light? Does it help to better see and determine if there are cancer cells or pre-tumor conditions? It seems this would improve predictions and decisions about whether or not to have a cystectomy.
Yeah, I mean, the blue light, sure. The blue light technology, I would say, has certainly increased our ability to detect cancers beyond our standard white light type of cystoscopy. The patient context that we're talking about in that for the blue light is the patient with earlier stage cancer, not the group we've been talking about mostly this evening. So I just want to make sure that's clear. But certainly the blue light can help us increase not only our detection of tumors on the surface, but some tumors that are invading into the layer below the surface, and some of the surface cancers that are high risk, the carcinoma in situ, that we believe are precursors to those that will invade. So it definitely has a role of improving our detection of cancers. It's not widely available across the entire country, although certainly many academic centers have access to it and some large urology group practices. But access can be an issue. Our guidelines that we use to guide treatment for patients with earlier stage bladder cancer does advocate for the use of the blue light when it's accessible to help improve our detection of cancers. And frankly, our studies that have been done have shown that using that technique can help improve our actual clearing of cancers from the bladder, so that the rate of recurrence is less over time for those patients.
So as far as white light, in terms of it showing better imagery of the blood vessels, does that make a difference either if somebody's using a white light cystoscopy? The blue light band. I'm sorry, narrow band. I'm sorry, I got that confused. Narrow band imaging.
Yeah, and Jim, I don't know if you want to take the narrow band.
Yeah, sure. Well, narrowband imaging does increase detection of tumors. It's not quite as sensitive as the blue light fluorescence cystoscopy, so it doesn't have quite the same amount of data to support it in the setting of non-muscle invasive bladder cancer, but it is something that is available and will increase detection. I think the question there was a great one, because these technologies are not generally talked about when we speak about muscle invasive bladder cancer, because they're oftentimes not as relevant in cases of muscle invasive bladder cancer. But when you're evaluating a patient post chemotherapy who appears to have no cancer, and you're thinking about doing something other than a cystectomy, I actually do think they make a difference to look for that carcinoma in situ, that hidden, subtle, early high-grade recurrence that might actually tip you over to say you do need a cystectomy. So in general, we do try to use blue light on post-chemo evaluations, because we even want to know if they have residual non-muscle invasive disease, because we don't want to watch them if they do.
Okay.
I should also comment that some years ago, when I was still at the University of Michigan, we did a number of studies trying to really determine the ability to use a non-standard type of chemotherapy for bladder preservation. So it wasn't the typical therapies that were used. At that time, it was gemcitabine. Now that's actually been shown to have reasonable results and be similar to some of the more standard therapies in bladder preservation. But at that time, it wasn't standard. What we found, though, is that even at 3 to 5 years, more than 2/3 of the patients who we had carefully selected and had undergone trimodality therapy, when they recurred, actually had tumors that were just on the surface. And we managed many of those patients just with intravesical therapies, and we were able to salvage the vast majority of them and still to preserve the bladder. So there certainly is a role for the patient who is very committed to bladder preservation. There is a role for intravesical therapies after systemic chemotherapy and or radiation in the bladder. That sometimes these tumors can be managed conservatively.
Mm-hmm.
And those are of course non-invading cancers, superficial types of cancers.
So I'm going to ask one last question, and then we'll conclude tonight's program. But if you had a crystal ball, obviously you'd be able to answer this one a little more clearly. But what is the recurrence rate after 10 years for cancer-free survival with bladders that have been preserved as compared to perhaps bladders that have been removed? You know, is there a way to do a comparison at that 10-year mark?
Well, this is a tricky thing, because a lot of the data that we have for bladder removal after surgery, the patient population is a bit different than the patient population that we have who have undergone trimodality therapy, and particularly more recently, the group undergoing trimodality therapy has gotten to be highly selected. I will say that a study was published within the last 2 years, I think it was 2017 perhaps, out of Canada. And they actually tried to compare, looking backwards, so it's not perfect by any means, but looking backward, they compared something like 55 or 56 patients who had undergone trimodality therapy to those who had undergone bladder removal. And although they don't have 10-year data, in the shorter term, and this is the shorter term, probably under 2 years, the outcomes were pretty similar. And these are patients that were not so heavily selected. A third of these patients had carcinoma in situ. Probably about 15% in each group had swollen ureters. And they tried to use a statistical method called propensity analysis to match the patients as if we were trying to randomize them, but certainly it's not the same. It's not the same. But that is a study that I can point to that's somewhat recent, so reflects kind of what we're doing more recently, and tried to compare the trimodality therapy group to the cystectomy group. So it's a very difficult study to even think about trying to do if we did it the old-fashioned way of getting a group of patients and randomizing them, because patients often have very real ideas about what kinds of therapies they do or do not want to have.
Wow. Well, thank you very much. I think this has been a phenomenal program. I'd like to once again thank Bristol Myers Squibb, EMD Serono, Pfizer, Behring, Genentech, Photocure, and Merck for making the Patient Insight webinar series possible. Remember that you will all be receiving an email with a link to a short program evaluation. Please take a few moments to complete these questions. Your opinions about this program are very important to us. We will be sending out the unedited footage tomorrow so that you'll have a chance to rewatch the program if you'd like. And I'd like to thank you all for joining us tonight. Thank you so much, Dr. Lee and Dr. McKiernan, for a phenomenal program.
Thank you, Stephanie.
Thanks so much, Stephanie.
Okay, take care. Bye-bye.